Dear students, I trust the NEET PG exam 2023 went quite well for you, and you'll be bringing us the happy news at the earliest possible. Today our task is to recall some of the questions which came to you, especially in terms of anatomy, and the happy news. We'll try to, let me just mention it this way, that since it is a recall, it is understood that it can't be perfect, but we'll try to reach the highest approximation to the exam conducted, the questions which came, and then there'll be a final video uploaded with all the proper discussion on the questions. But at the moment, I just want you to contribute to the wordings of the questions, the stem, the diagram, the options given to you. And the purpose of this is very simple. First of all, you will feel confident that whatever answer you have given was correct. And the second thing is, it will give us some orientation about the topics which the examiner is interested in asking very frequently, and maybe some of the juniors who are preparing for their INI-CET exam or the next All India PG exam, they will be helped in the process. Now, it is understood that any change in the stem of the question or any change in the options can very well change the thought process and the orientation of the question and can change the answer. So we have to be careful about that. Now, as I start, you will see this is the very first question which I have gathered from the students. Of course, these are all recall-based questions. So in this question, we are having identify the arrow-marked structures in the microscopic picture and the options. You should always read the options quickly. Islet of Langerhans, that is the endocrine portion of pancreas, or lymphatic nodule, lot of blue dots, the lymphocytes, and interstitial cells of Leydig, that is, in the testis, the seminiferous tubule, the Leydig cells giving testosterone hormone, and renal glomeruli. So, as I understand, most of the students, they have mentioned, this was actually a diagram which belong to the, these arrow mark basically, and they are nothing but the renal glomeruli. I'll be doing a detailed discussion on the topic, but since this is a quick recall, what I find is the proper answer to this question should have been renal glomeruli, the kidney basically, because what you find is, you see here, we are looking at, say, these are the PCT and DCT which are around the renal glomeruli, the proximal convoluted tubule, the distal convoluted tubule, and the renal glomeruli is identified with the fact that there will be some capillary plexus, and there is a space, around the, you can see here, around the capillary plexus, which is glomerulus, there is a renal space where there will be ultrafiltrate of blood, and that is what is called as the urine. So this slide belongs to the renal glomeruli. Now, looking at the next question, you will see that here it is asking for lesion of which of the following structures will lead to, you see, loss of vision. Let us take a dark color. Loss of vision in the right half of each eye. That means it is right half of each eye is blind. It is called as homonymous hemianopia. And if it is homonymous hemianopia, where could be the lesion? Before we mark the answer, you can just have a look here. See, this is the superior view of an individual who is just lying supine, and as we are following, this is the right eye, and this one here, the orbit, the right eye, and this is the left eye. So we are looking from superior view, left eye and the right eye, and talking about the pathway. So it is understood, right eye, the temporal vision, or what you call as peripheral vision. If you follow that, you will notice the peripheral vision, temporal vision of the right eye is reaching the nasal retina and then crosses the midline in the optic chiasma. and then reaches the opposite-sided lateral geniculate body. Then it will reach the left-sided occipital visual cortex. So peripheral vision, which comes to nasal retina, will be crossing the optic chiasma, going to the opposite side lateral geniculate body and to the occipital visual cortex. So this is happening on the right eye, say peripheral vision coming this way. Similarly, peripheral vision of the left eye will also cross in the midline, that is optic chiasma. So we can see that temporal field or the peripheral field of the left eye is received by the nasal retina, crosses in the midline, and then go to the contralateral geniculate body and then the occipital visual cortex. This will tell us about the crossing fiber. What about the nasal fibers? As you talk about the nasal fibers, you will notice that if it is right eye now, the nasal vision will go to the temporal retina, continue ipsilaterally on the same side and reach the occipital visual cortex. So if you are talking about the right eye nasal vision, it will go to the temporal retina and continue on the same side. Means the nasal field goes ipsilaterally, temporal field goes contralaterally. You can say the same thing about the left eye now. The nasal vision is going ipsilaterally. So the nasal vision of the left eye is going ipsilaterally. That will give us the idea that if there is a lesion, let us now change the color here. If there is a lesion in the left optic radiation, then you will find there will be a contralateral homonymous hemianopia. Right half of each eye will become blind. So here, as you see, this is a normal binocular vision, and if we have a left-sided optic tract lesion, then right half of each eye will be blind. You see, this is gone. This half is gone. So right half of each eye is blind because there was a lesion on the left side. Now, how is it different from the occipital cortex? In occipital cortex, because there's dual supply, there'll be a central sparing, macular sparing. So this macular sparing is not mentioned. So we cannot say occipital cortex. And moreover, it could be optic tract also. Even the lesion of optic tract or the optic radiation, it gives the same kind of feature to us. But if it is a pituitary tumor, like there's a central pituitary tumor, then it will be the bitemporal hemianopia. Or if it is just a lesion of the optic nerve itself, then the same sided eye will be blind. So these details you already know. The point is, what is the answer to our question? As you go back to this question, you can understand we were being asked about the lesion. Loss of vision on the right half of each eye. Right half of each eye. Homonymous hemianopia. Contralateral lesion should be there. Left-sided. Left-sided, it could be the optic tract or it could be left-sided optic radiation. Cannot be occipital cortex because there is no mention of macular sparing or central vision sparing. That is not mentioned, so we cannot take this answer. Otherwise, it is also contralateral homonymous hemianopia. Now, moving on to the next question, you see here, this is a typical history which you have to focus upon. There is a patient which is quite old, 55 years post middle age, and then presenting with confusion. And there's a history of fall 1 week back. So it becomes chronic. What is the chronic? Here he is having a chronic alcoholism history also, and non-contrast CT scan is showing the following picture. So what you see here, as you can notice yourself, let me take a color which is evident. You will notice that this is the appearance of the hematoma. Now, could be confusing because it is biconvex, appearing biconvex, though not necessarily. It depends which picture was given to you. But then if you go by the history, old people, when there is brain atrophy and alcoholism, again there is brain atrophy, and it is a fall. which the patient did not present immediately. If it was immediately presenting patient, then it could be, epidural hematoma. But this is a venous bleed, and venous bleed, and actually multiple venous bleeds, because these people, they keep falling frequently. So the bridging veins basically compromised, and you are thinking in the same direction, subdural hematoma. So it is SDH. Now, if you say it is SDH, why? It can be acute, but mostly it is chronic and is not an emergency, though it could be emergency. Now, what about extradural? If you say extradural is mostly emergency and it is arterial bleed. So there will be loss of consciousness and it will worsen quickly. So not the patient will be coming after 1 week to you. And what about subarachnoid hemorrhage? Again, acute presentation. So these are acute cases and they don't come after 1 week to you. And intracerebral hemorrhage, like a lot of discussion is there, but quickly going through the details, because we don't know exactly what the wordings, the stem of the question was, which picture was there. We're just trying to gather the information, and finally we'll make a detailed video. So in here, I believe that our answer should have been subdural hematoma. Let's go to the next question. As we proceed further, this is a patient, a female, 75-year-old female patient, inability to express feelings. Mask-like faces, bradykinesia, tremor, rigidity, hypokinesia. So tremor also very typical, pill rolling tremor they might have. Rigidity, if you are talking about, then it will be, lead pipe rigidity or cogwheel rigidity. If you say hypokinesia or bradykinesia, inability to initiate the movement and inability to stop the movement. Both of them are there. So basically, we are talking about basal ganglia problem. Now, hippocampus is for short-term memory, conversion of short-term memory into long-term memory, all those details. Cerebellum is basically for coordination of voluntary motor activity. Though remember, coordination is also the feature of basal ganglia. Be careful. But coordination, when it comes, coordination of voluntary motor activity, first answer should be cerebellum. But this is not a problem of coordination here. And then internal capsule, there'll be contralateral problems, hemiparesis, hemianesthesia and all that. So this question, as I understand, the answer goes more in favor of basal ganglia. You can have a look over the patient as well. These patients will have a typical, what you call as the shuffling gait, because there is a difficulty in initiating the movement, and once they initiate the movement, then there is difficulty in stopping the movement. So rapid shuffling gait and mask-like faces, as it is mentioned, inability to express feeling of happiness or sadness, all that. They have mask-like faces, and pill rolling tremor and stooping posture. So these are all basal ganglia problem. Basal ganglia is basically for planning and programming of the voluntary motor activity, so that the movements are smoothing of movement. Now, as we proceed further, you will see this is one question which is asking us about the lateral path of the dorsal column in the cervical region. You see, dorsal column carry 5 sensations like pressure, the touch, the vibration, conscious proprioception, because it is reaching the cerebrum, that is why conscious proprioception, and stereognosis. So these 5 sensations are carried by dorsal column. Now it is telling lateral part of dorsal column. If you take a spinal cord transverse section, say this is the central H-shaped gray matter, and in the periphery you will have white matter. In the white matter also, if you look on the dorsal side, there will be 2 columns. Medially, it is the fasciculus gracilis, which brings information from the lower body below diaphragm, and laterally, it is the fasciculus cuneatus, which is bringing information from the body above diaphragm, upper trunk, upper limb. Now you can understand, since they are mentioning, already it is given here, let us take this color, that already they are mentioning injury to the lateral part of the dorsal column, because it runs on the dorsal side of spinal cord. Lateral part of the dorsal column, it has been compromised in the cervical region. In the cervical region, that means cervical region, thoracic region give you brachial plexus for the upper limb, isn't it? So fasciculus cuneatus, C5, 6, 7, 8, T1, brachial plexus. So the point is that if you are talking about proprioception, of course it is dorsal column, and since it is cervical region, must be the upper limb. Now, dorsal column, when it takes the 5 sensations from the upper limb or from the lower limb, dorsal column runs ipsilaterally in the spinal cord, and it crosses at the level of medulla oblongata, so that it can continue as medial lemniscus, and then going to the thalamus, to the contralateral, central, postcentral gyrus, parietal sensory cortex. But initially the proprioception is running ipsilaterally in the spinal cord, and this is a description of dorsal column which is in the spinal cord. So ipsilateral, the proprioception of this limb will be running ipsilaterally, and if it is damaged, then you can see it is ipsilateral upper limb which will lose the sensation. So here our answer should be ipsilateral upper limb. Now, moving on to the next question. This is one question which is asking us about congenital anomaly shown in the diagram. Relates to which of the following arch artery? So pharyngeal arch arteries, which contribute to various vessels like carotid vessels, subclavian or arch of aorta, pulmonary arteries and all that. So what is this defect? You can see here one thing which is being evident here. Let us use the green color. The blood, which is, this is superior vena cava, inferior vena cava, bringing blood into right atrium, into right ventricle. From right ventricle, it is going towards the pulmonary trunk and pulmonary artery to the lungs for oxygenation. But some of the blood is now, there is a communication of the left-sided pulmonary artery with the arch of aorta. Initially, during fetal circulation, the blood is from the pulmonary circulation, means pulmonary artery, towards the arch of aorta. But when the baby is born, when there is adult circulation, blood can reverse also. That Eisenmenger complex and all those things will come. But the point is, they are basically talking about patent ductus arteriosus. Normally, there is a ductus arteriosus in the fetal circulation which must be obliterated. But if it is patent, then there will be problems. There can be intercommunication, mixing of blood, the right to left shunt. But then it can be, as it reverses, left to right shunt, mixing of blood, cyanosis, cyanotic heart disease. Anyhow, it is asking which arch artery is related. So as you can draw a diagram quickly so that you can discuss the details and then the answer. See, if it is the heart, 4 chambers, it is understood it is the left ventricle which will be giving us the arch of aorta. And from the arch of aorta, let us shade it with some color. Say it is the left ventricle which is sending the blood into ascending aorta, then it is the arch of aorta. And from the arch of aorta, you'll have the, vessels like brachiocephalic trunk, and then the left-sided common carotid artery, left-sided subclavian artery. 3 vessels come from the arch of aorta. Now, as we still go down, you will find that it is the brachiocephalic trunk, which will then give us the right-sided subclavian artery and the right-sided common carotid artery, whereas left common carotid artery is direct branch from the arch of aorta. Then what about the pulmonary trunk? It is the right ventricle which will give us the pulmonary trunk, and this pulmonary trunk then will be dividing into 2, that is, right pulmonary artery and the left pulmonary artery, so that blood can go to lungs. This is adult circulation. But adult circulation which has come, what is its embryological derivation? Some pharyngeal arch arteries were there. Like, let me mention here, if you talk about the right-sided common carotid artery and its continuation, which is right-sided internal carotid artery. Or maybe it is left-sided, common carotid artery, continuation, left-sided, internal carotid artery. You have to understand that if we are talking about the common carotid artery or internal carotid artery, especially the proximal part, they will come from the pharyngeal arch artery number 3. So pharyngeal arch artery number 3, pharyngeal arch 3 gives us the common carotid and internal carotid proximal part. What about the fourth arch artery then? When we talk about the fourth arch artery, you can see here on the right side, it will give proximal right subclavian artery. So pharyngeal arch number 4 on the right side will give us right-sided subclavian artery proximal part, this much. Whereas the pharyngeal arch artery 4 on the left side will give us the arch of aorta lying between two vessels, basically the left common carotid artery and left subclavian artery. So this portion of the arch of aorta is coming from fourth arch artery and left-sided pharyngeal arch artery 4. So pharyngeal arch artery 3 will give us carotids. Pharyngeal arch artery 4 on the right side give right subclavian partly, and the left pharyngeal arch 4 will give arch of aorta partly. That is fourth arch. Fifth arch arteries, they disappear in humans. Sixth arch artery, if we are talking about, then it is understood that it is the, you can show here, it is the right pulmonary artery and the left pulmonary artery. So when we are talking about pharyngeal arch artery number 6, they give us the pulmonary arteries, maybe right side or left side. But on the left side, in fetal circulation, there is one more structure, and that is when you connect the left pulmonary artery with the arch of aorta. This is called as ductus arteriosus, and even the ductus arteriosus is coming from pharyngeal arch artery 6. Now, pharyngeal arch artery 6, if it is right-sided, the ductus arteriosus kind of structure disappears. It is only on the left side that it will be persisting, but that also in the fetal circulation. Or pharyngeal arch artery will definitely form pulmonary arteries on both sides and ductus arteriosus both sides, but right regresses and left is left. Means ductus arteriosus is present only on the left side, not on the right side normally. And ductus arteriosus, which is present on the left side, is in fetal circulation, not in adult circulation. So what if it is persistent, which can be congenital cyanotic heart disease, or later it becoming hyperarrhythmic heart disease because there's a reversal of shunt, all those things. But basically they were asking which arch artery problem. Obviously pharyngeal arch artery number 6. So as you come back, you will find this question is basically asking us about the ductus arteriosus, patent ductus arteriosus, and if it is so, then what should be your answer? Left-sided sixth arch artery, of course, that is your answer. A detailed discussion coming up later, but at this moment we are just trying to take care of the questions. Now this patient is having progressive pain in a swelling below ear lobule. So below ear lobule, you have pain. Now they're asking which of the following structure is responsible for the pain. Now if you talk about the greater part of auricle, maybe laterally or maybe medially, it is the greater auricular nerve, and greater auricular nerve also with the root value C2, C3, because it comes from cervical plexus, is carrying most of the pain. For example, if you do a ear piercing laterally as well as medially, the nerve is greater part of auricle is supplied by greater auricular nerve. Problem with this question is that they have mentioned deep cervical fascia also. So what about your answer? Is it C or is it D? Because both could be the answer. In fact, what happens is deep cervical fascia in the neck region gives us certain modifications, and one of them is investing layer of deep cervical fascia. So actually parotid gland is covered by deep cervical fascia, And if there is a swelling of parotid gland, which can obviously go inferior to the ear lobule, if this is the case of some parotid swelling, first of all, as the students mentioned, and the pain is due to stretching of the unyielding parotid fascia. Parotid gland, parotid capsule, that is deep cervical fascia, is so unyielding that any swelling which happens here will be very painful because the fascia is unyielding, doesn't allow the swelling. Obviously, pain is due to stretching of the cervical fascia, but who is carrying the pain in this area? That is greater auricular nerve. So it is now controversy that should I take my answer as the choice number C or D. So I'll gather some more information and then talk more about when we release the final video. For the time being, maybe I'll keep my answer as deep cervical fascia, means D appears to be a better answer than C. But we have to actually discuss a little bit further with ENT professors as well. Then we can reach the final answer. Now, as we move further, this is one question which is asking us 5-year child, features of acute tonsillitis, referred otalgia. So this is a case of referred otalgia, ear pain, tonsil area, posterior 1/3 of tongue, tonsil, soft palate, oropharyngeal isthmus, that is all under glossopharyngeal nerve. But glossopharyngeal nerve also supplies middle ear cavity. So that is the description of referred otalgia. Because the tonsil is supplied by 9th nerve, even middle ear cavity is supplied by 9th nerve, there can be, the brain can feel as if the pain is coming not only from the tonsil but also from the middle ear. That is why ear pain. So tympanic branch of glossopharyngeal nerve is the answer here. And more details in the detailed video, as I am telling again and again. Now this child is presenting with the stuck open mouth. In our clinical practice, there used to be some cases, and our orthopedician, our SR, will tell us, don't, because in night duties we are tired and really don't do that. Otherwise, a muscle can go into spasmodic contraction. So spasmodic contraction can happen if you are overusing this muscle. Which muscle opens the jaw? Lateral pterygoid, because this is MTM, and MTM are elevators of the mandible. They close the mouth. Only one muscle is here which is opening the mouth. So of course, when you are yawning, you have to open your mouth, and the only one muscle which opens the mouth is lateral pterygoid. And lateral pterygoid, say if you're looking for the mandible from this view, from the right side, this is the condyle of mandible, this is cornoid process, and the ramus of mandible, and then there's a temporomandibular joint. This is the temporal bone here, and there's a tubercle on the temporal bone. Now this is the joint capsule, which is of course connecting the mandible with the temporal bone, TM joint. And in the TM joint, we also have a disc, which is articular disc. So this is the articular disc. Articular disc attaches to the capsule and divides the cavity into two parts, upper cavity and lower cavity. Temporomandibular joint has one articular disc and a muscle which pulls the mandible and depresses the mandible is lateral pterygoid. Now, where is lateral pterygoid muscle attaching? Because it is moving the mandible, it must be inserting. So it comes from pterygoid plate, sphenoid bone, but that is origin. We are talking about insertion here. Insertion to the pterygoid fovea. So pterygoid fovea in the neck of the mandible. So in the neck of mandible, there is a pterygoid fovea for the lateral pterygoid muscle, and so that this muscle can pull. That is the function, pull. But not only it is a protruder, but it is also the MTM muscles are elevated, lateral pterygoid is a depressor. Then only you can open the mouth. So it is a protruder and depressor. Now, when you are yawning, excessive yawning, this head of the condyle of the mandible can go in front of the tubercle and stuck there. And if it is stuck there, it finds difficulty coming back, and that is subluxation of TM joint or dislocation of TM joint. And if that happens, mouth will remain open, and the surgeons will then, they have a technique to push it back. So this condyle, if it goes here, you can push it back. But why it gets stuck there? Due to spasmodic contraction of the lateral pterygoid. So our answer, as you can make out yourself, should be choice number A. That is our answer in this particular question. Now we can move on to the next question. As we see, a lot of questions in the head neck region, neuro area. Now, this is one congenital anomaly they are talking about. And in this congenital anomaly, diagram is there. No, this is a wrong formatting of the question. Congenital anomaly is giving us, relates to which ligament? That should be your question. And as the ligaments are given here, falciform ligament or medial, median or lateral umbilical ligament. So something to do with the developing gut tube. Now, to draw a simplified diagram, this is the gut tube which divides into three parts: the foregut, the midgut, and then the hindgut. And then there are some diverticulum. There is a midgut diverticulum which is connected with the yolk sac, called as vitalo-intestinal duct. And then there is a hindgut diverticulum which also become a content of umbilical cord, and that is called as the allantois. They have marked the allantois here. As I'll tell you once again, as we are talking about the gut tube, this is the foregut. Then we are looking at the midgut. Let us change the color. This is the midgut. That is the midgut. And then we have the hindgut. So this is the hindgut. Hindgut diverticulum, that is allantois, in fetal circulation. And the midgut diverticulum is the vitalo-intestinal duct. But both of them are content of the umbilical cord. In umbilical cord, you will have a midgut diverticulum, that is vitalo-intestinal duct. And in the umbilical cord, as we are telling, this is going to be the umbilical cord, is the hindgut diverticulum allantois. Now, they are functional, patent only in the fetal stage. In adults, they'll be obliterated. So, vitalo-intestinal duct will be obliterated. It should not stay anymore. Even the allantois will be obliterated to become what is called as urachus. And this allantois, which has become urachus, keep attaching to the apex of urinary bladder, the urinary bladder which develops in the cloaca region of the hindgut. So in the hindgut, you have cloaca region, there is urinary bladder developing, attaching to the apex of urinary bladder is the allantois, which then changes into urachus. And over that, there is some peritoneal fold in the anterior abdominal wall, below umbilicus. So below umbilicus, covering this urachus will be, urachus is nothing but fibrous structure, a remnant of allantois, covered by some peritoneum. That peritoneal fold is called as, because it is only one, there is one urinary bladder, one urachus. So one in the midline, median umbilical ligament. So as we say, the answer to this question should be the median umbilical ligament. Let me show you a diagram also. Anterior abdominal wall and showing some peritoneal folds. And in those peritoneal folds, as we are suggesting, if we are talking about the urinary bladder. So this is the urinary bladder. Attaching to the apex of urinary bladder was allantois in fetal stage. But now in adults, it will become the urachus. And that urachus is raising, it is covered by some peritoneal fold in the anterior abdominal wall below umbilicus, that is median umbilical fold. So median umbilical fold is basically the urachus, which is allantois in the fetus. What about falciform ligament? Falciform ligament is the peritoneal fold, which is covering left umbilical vein in the fetus, which has now become ligamentum teres of lever in adults. So in adults it is ligamentum teres, but in the fetus it was left umbilical vein. It is covered by some peritoneal fold above umbilicus, and that peritoneal fold is falciform ligament. So falciform ligament is basically covering what? Falciform ligament is basically covering the ligamentum teres of lever. Then what is this peritoneal fold here, which is called as medial L? This is L, that is N. So there are two medial umbilical folds. They are also peritoneal folds. What are they covering? They are basically covering the obliterated umbilical arteries, because the umbilical arteries, they work only in the fetus. So obliterated umbilical arteries, and they have no function as such. They have become ligaments and covered by some peritoneal fold. So that is called medial umbilical fold. And what about the lateral then? There is one lateral also, as you can see. This is the lateral umbilical fold. Then what is it due to? This lateral umbilical fold is raised by some vessels, inferior epigastric vessels. So as we talk about these vessels, they are the inferior epigastric vessels, which are coming from the external iliac vessels and going to enter the rectus sheath, covered by some peritoneum, and that peritoneal fold, two lateral folds because of inferior epigastric vessels, artery vein, and two medial umbilical folds, which are due to obliterated umbilical arteries. And our answer was urachus, or the median N umbilical fold. So as you come back to your question, we already have marked the answer. The question was asking congenital anomaly. In the diagram, which ligament? And your answer is median umbilical ligament. Actually, this is a ligament. They are covered by some peritoneum. So that peritoneum is called as the fold. So median umbilical ligament is what? It is urachus, and it is covered by fold that will be called medial umbilical fold. Similarly, what is medial umbilical ligament? Adult remnant of umbilical artery, and it will be covered by a peritoneal fold simply called as medial umbilical fold. Similarly, lateral umbilical ligament is what? It is basically, now be careful here, the lateral umbilical ligament is the name given to the peritoneal fold. Peritoneal fold, because the arteries, the vessels are still working. They have not become some ligament. So which vessels? Inferior epigastric vessels. That is why, sometimes we try to go very superficial, and which is, dangerous, because we skip some information which can actually be damaging. So I'll talk more in detail when the question comes in the actual video discussion. Let's move on to the next one. As you see, this is one question which is now asking us, a patient presented with loss of sensation over lateral 3.5 fingers and palmar aspect. So palmar 3.5, it is obvious that we are talking about the median nerve. And as you say median nerve, then there is no problem at all. Immediately we can rule out at least Guyon's canal, because Guyon's canal is for ulnar nerve. So now, if it is carpal tunnel syndrome, we are talking about, do we do Froment test for median nerve? No, it is for ulnar nerve. So the only possible answer is carpal tunnel and Durkin test. What is Durkin test? Like, you do all those tests for your median nerve, Tinel sign also. You just have to compress the median nerve. This is the flexor radiculum, proximal to that, and keep compressing it for 30 seconds. And if the patient complains of tingling sensation in lateral 3.5 fingers, it goes in favor of something wrong with the median nerve. That is Durkin test. It is a modification of Tinel test as such, regenerating median nerve like that. But anyhow, Durkin is for median, Froment is for ulnar. More details in the discussion coming up. Here the answer should be choice number D. Now, as we proceed further, this is one question which the student told that maybe it was, hand-drawn diagram, or maybe it was a live or a cadaveric specimen, but this is the marker, and it is none other than deep inguinal ring. Now, if you're talking about deep inguinal ring, it is understood it is a defect in the fascia transversalis. If you're talking about superficial inguinal ring, then it is a deficiency in the external oblique aponeurosis. Like you can draw your diagram here. You see, there is one fascia transversalis, the deepermost, because we are talking about abdominal inguinal region, abdominal layers. So deepermost is the fascia transversalis. There's an opening, that is deep inguinal ring, and then three muscles: transversus abdominis, internal oblique, external oblique. So as you go to the next muscle is the transversus abdominis, and still next is internal oblique muscle, and still next you can just use some other color. Maybe we can use this one. This is external oblique muscle aponeurosis, and it is having one opening here which is called superficial inguinal ring. Now what you can do is you can bring the testis, because testis in the baby is developing in the abdomen, then it comes to inguinal region, then comes out into the scrotum. So follow the testis. As you follow the testis, you will see testis has to migrate from deep inguinal ring, inguinal canal, and then superficial inguinal ring, and then come into the scrotum. So as the testis, say this is, take some dark color, as the testis, you follow the testis, it is entering the deep inguinal ring, which is a defect in the fascia transversalis. Then it will be moving in the inguinal canal, and then it will come out of superficial inguinal ring to enter the scrotum. And what is this defect superficial inguinal ring in? That is external oblique aponeurosis. So deep ring, superficial ring, deep ring, superficial inguinal ring. Then it will go into the scrotum. The point is, what is the other two structures here doing? They just form a roof over them. Say if it is, let us say this muscle, that is transversus abdominis, roof and posterior wall. What about the internal oblique? Internal oblique also will form roof and posterior wall. And when they are forming the posterior wall, they actually together form conjoint tendon. So this is what we call as the conjoint tendon. Conjoint tendon is in the posterior wall of the inguinal canal. This testis path is then followed by spermatic cord. This is spermatic cord because if this is testis, then testis will be sending sperms back into urethra. And as the testis is sending the sperms back into urethra, you will see that the sperms are running in the ductus deferens, which is the content of spermatic cord, and sperms will enter the spermatic cord. Spermatic cord is passing through superficial inguinal ring, inguinal canal, having a roof of internal oblique, transversus abdominis, and then defect in the fascia transversalis, and then go into the urethra for ejaculation. Plus, this spermatic cord will also have testicular veins, because there's a structure here, it will send venous blood. Testicular veins will also be running inside the spermatic cord, going towards the inferior vena cava. And from the abdominal aorta, the testicular arteries will be following the testicular veins to reach the testis, all content of the spermatic cord. So this is one thing which we wanted to know, because the question is asking an atypical structure, arrow mark, deep inguinal ring, is a defect in fascia transversalis. I am just working for the next question. Next question was asking us about the direct inguinal hernia. So let us move on to that as well. But here, as you see, the answer to this particular question, deep inguinal ring, is fascia transversalis. Now, as we move on to the next question, what you notice is, this is the question. It is asking us about the hernia, which is lying medial to inferior epigastric artery. We have just discussed inferior epigastric vessels. They are raising some peritoneal fold called as lateral umbilical ligament or lateral umbilical fold. Umbilical fold and ligament, they are used interchangeably in case of lateral umbilical structures. So this is the same inferior epigastric artery, and it is a hernia superior to pubic tubercle. If it is superior to pubic tubercle, must be inguinal hernia. If it is inferior, femoral hernia. So why do you have this? And medial to inferior epigastric means it is direct. So it is direct inguinal hernia, and usually in adults and weak musculature, you see, tendon, the conjoint tendon. This is your answer. Now, to have more details, you can just move on to this diagram. You see, looking from the front view, as you notice, we are looking on right side inguinal canal. Right side inguinal canal, front view. There is anterior superior iliac spine, right hip bone, pubic tubercle, right hip bone. Connecting the two will be a ligament, inguinal ligament. Inguinal ligament is nothing but it is modification of external oblique aponeurosis, forming not only anterior wall but also floor of the inguinal canal. So attaching to hip bone at 2 points, anterior superior iliac spine and pubic tubercle, is the inguinal ligament, which is nothing but the tendon aponeurosis modification of external oblique aponeurosis, forming anterior wall and floor of inguinal canal. It again has some modification. You see, inguinal ligament is giving one modification attaching to pectineal line on hip bone. So it is called pectineal ligament of Cooper. So what you find now here is called as pectineal ligament of Cooper. And between the two, you will notice there is a connection, some fibers, and that is lacunar ligament running anterior posterior. So which is most anterior? Inguinal ligament. And which is most posterior? Cooper ligament. Pectineal ligament of Cooper. What is between the two running anterior posterior? Is lacunar ligament. But none of them relates to inguinal hernia as such. When we are talking about direct inguinal hernia, they are more related to the femoral hernia. You see, the femoral hernia will be coming from here. So if you say femoral ring, femoral hernia, anterior boundary, inguinal ligament, posterior boundary, pectineal ligament of Cooper, medial boundary, lacunar ligament. In surgery, you cut the lacunar ligament to reduce the femoral hernia. So this is all related with femoral hernia. Of course, it is related with inguinal hernia also, but more with the relation of femoral ring, femoral hernia. Then, what about the patient which we were talking about? As you talk about this patient, let us revise the things once again. It is the same information, but kind of a revision. Say, I told you there is fascia transversalis. There is a defect in fascia transversalis, and that is deep inguinal ring, through which, if a hernia comes, then we will call it as the indirect inguinal hernia. These vessels, inferior epigastric vessels, are the boundary line. If the hernia is lateral to that, it is indirect inguinal hernia. Like young boys, they can have indirect inguinal hernia. Old people, they will have it medial to that. Like here, the direct inguinal hernia. So this becomes a boundary line. Inferior epigastric vessels, which were raising the lateral umbilical fold, if you remember, peritoneal fold below umbilicus. So any hernia which is lateral to that is young adults, usually young boys, indirect inguinal hernia, mostly congenital variety. And if the hernia is medial to that, direct inguinal hernia, mostly early acquired defect due to loss of tone of the abdominal muscles. Now, as you see, what is the posterior most structure here? Posterior most structure here is the fascia transversalis, as we have mentioned. This is the fascia transversalis. And what is next to that? Transversus abdominis muscle. We mentioned transversus abdominis muscle is basically forming the roof and posterior wall of the inguinal canal. And then we have one more muscle. Let us change the color. Internal oblique. Internal oblique is also forming the roof and posterior wall, and together they will form what is called as the conjoint tendon. That is the conjoint tendon. So conjoint means two muscles together. Which one? Internal oblique and transversus abdominis. And then which muscle is always anterior to the inguinal canal? And that is external oblique aponeurosis. As you can see, let us use the green color here. And as is evident, this external oblique muscle remains anterior, and it is the ring which is we are calling a superficial inguinal ring. And then talking about the testis, we can mark it here. Say this is the spermatic cord which is passing through the two rings, deep ring as well as superficial ring. Actually, it was the path of testis, and then it is the path of spermatic cord, which is having ductus deferens with sperms going back to urethra, and testicular artery, testicular vein, and all that. Point is, the examiner is telling, there is one hernia medial to the inferior epigastric vessels and superior to pubic tubercle. I told you, elderly people, weak musculature. If the conjoint tendon is weakened, stretched, there might be some urinary bladder coming out through the superficial inguinal ring, direct inguinal hernia, or even some intestine, or even omentum. So enterocele, omentocele, vesicocele. So that is direct inguinal hernia. That is what the examiner was asking us. So as you go to the question, you will find this was our question, and already we have answered. If it is a case of hernia lying medial to inferior epigastric vessels and superior to pubic tubercle, if it is superior to pubic tubercle, inguinal, inferior to pubic tubercle, femoral hernia. So it is inguinal, direct inguinal hernia, and conjoint tendon is your answer. Moving to the next question, you will find there is a patient who is presenting with pain in the right leg. Now be careful. It is not lower limb. It is not thigh. Be careful. Right leg. The students told me it was not thigh, it was not lower limb, it was leg, below the knee joint. What is your answer? Patient presented with pain in the right leg past 3 months. There was laparoscopic bilateral inguinal hernia repair. You know, when it is laparoscopic surgeries, endoscopic surgeries, the nerves which get compromised are in the triangle of pain. That is basically the lateral cutaneous nerve of thigh, resulting in myalgia paresthetica. Or the other one could be femoral branch of genitofemoral nerve, because they are in the triangle of pain. So when you are putting a tacker or putting a mesh, might be entrapped, and maybe pain in the thigh, if it is lateral thigh or anterior thigh, because femoral branch genitofemoral is anterior thigh over femoral triangle. Is that your answer? And if you say ilioinguinal and iliohypogastric, they are compromised not in laparoscopic surgeries but open surgeries. You know, femoral nerve can be damaged in laparoscopic surgeries. Laparoscopic surgeries, because they are close to, it is close to these two nerves. So my point is the answer femoral nerve? I think the answer is femoral nerve. Pain in the leg, saphenous nerve. And saphenous nerve is a branch of femoral nerve. Maybe in laparoscopic injuries, laparoscopic hernia repair, there may be damage of femoral nerve, though it is rare. But if it is damage, maybe the examiner was targeting this answer. So controversy we'll discuss and then bring you the final video. But as you see, let me show you the details, what I'm talking about. See here, you have to understand, if we are talking about open surgeries, then the problems would be with ilioepigastric and genital branch of genitofemoral. This is open surgeries. Okay. What about the laparoscopic surgeries? In laparoscopic surgery, 3 nerves can be compromised. So which 3 nerves can be compromised? The femoral branch of genitofemoral, because it is a content of the triangle of pain, and then it is the lateral femoral cutaneous nerve also. So as you talk about the laparoscopic surgeries, in laparoscopic surgeries, you can have problem with femoral branch of genitofemoral and lateral femoral cutaneous nerve, but you can also have problem with, very rare, but the femoral nerve. And if femoral nerve is damaged, you will have a problem with saphenous nerve, leg. See, there is a difference between leg and thigh. And together this is called lower limb. So examiner did not say lower limb. Examiner did not say thigh. He has mentioned leg. Leg means saphenous nerve. Saphenous nerve means though rare, but it is a problem of femoral nerve. So I understand it is kind of a, even the ilioinguinal nerve, you should remember, is damaged in open surgeries. So when you are talking about open surgeries, ilioepigastric, ilioinguinal, this territory basically, this territory can be involved in open surgeries. And the rest of the territory is involved in laparoscopic surgeries. This also laparoscopic surgeries. More details in the upcoming video. But at this moment, there is a case of liver cirrhosis. Now, if it is liver cirrhosis, it is understood fibrosis of the liver, back pressure. The blood from the liver is not able to reach the inferior vena cava. Means portal vein, portal circulation is unable to drain into systemic circulation, backflow, portal hypertension. And then if there is a portal reversal of blood flow and portal hypertension, then some anastomosis has to open. See, what happens is, it is understood that there is this inferior vena cava. It is systemic circulation. Inferior vena cava is systemic circulation. Systemic circulation means it will bring blood from lower limb, pelvis perineum, like that. Abdomen region also, but not the, it is the body wall, not the gut. So where is gut draining? When we talk about the gut, maybe it is, spleen also. From the spleen, there will be a splenic vein. From the hindgut, you will have the inferior mesenteric vein. From the midgut, you will have the superior mesenteric vein, together forming portal vein, and portal vein draining into the liver. So this is portal circulation. So when it is, you can follow it again, when you are talking about the hindgut. When you're talking about the hindgut, the inferior mesenteric vein draining into the splenic vein, which both of them, the blood will be received by midgut vein, superior mesenteric vein, and then together they are forming portal vein. This is portal circulation. It will have venous blood full of nutrients coming from the gut tube, and it will also receive what is called as the left gastric vessels from the stomach, left gastric veins basically from the stomach, because that is foregut. So foregut drains directly into the portal vein. So left gastric veins, stomach basically, will be draining directly into portal vein and then into liver. Now liver itself will send some veins, like you can show here. hepatic veins, 3 in number, and those hepatic veins then drain the metabolites, because whatever gut nutrients came to liver will be metabolized, and the metabolites will be then poured into hepatic veins, and from the hepatic veins into the inferior vena cava. So portosystemic circulation, because all the blood ultimately has to come into inferior vena cava below diaphragm. Body below diaphragm has to drain into inferior vena cava, then inferior vena cava will drain into the heart will drain it into the lungs for oxygenation. This is venous blood. We are talking about the veins here, isn't it? Now, sometime if there is liver cirrhosis, then the blood will start coming back, reversal of blood flow. And if there is a reversal of blood flow, you will see where this blood has to go. If blood cannot enter inferior vena cava because there is fibrosis of the liver, cirrhosis of liver, portal hypertension will be there, and this blood will come back. So portal vein will have portal hypertension. This blood can go into left gastric vein, and then from there it will go into the esophageal vein, and from the esophageal vein it will go into what is called as superior vena cava. It will go into superior vena cava because eventually you have to drain the blood into the heart. If you cannot drain the blood into IVC, you will drain into SVC. Let me show you a diagram for the same. This is one way of sending blood into systemic circulation, and in that process there will be esophageal varices. Similarly, there can be rectal varices. This blood which you are following can go back into inferior mesenteric vein, superior rectal vein, and then into the middle inferior rectal vein, rectal varices. So in portal hypertension, we can have rectal varices, or we can have the esophageal varices. Esophageal varices can bleed hematemesis, and rectal varices can bleed fresh blood per rectum. So all that we have to now focus upon. But what about the answer? As you will notice in this question, if you are talking about anastomosis, it is portosystemic anastomosis. So one of the pair should be portal circulation, one of the pair should be systemic circulation. That will help us. Left gastric vein is portal and esophageal vein is systemic. So that is fitting quite well. Middle colic vein is portal circulation. Left colic vein is portal circulation. So if it is portal plus portal, it cannot help us. We need portal and systemic anastomosis. It is not helping. Sigmoidal is coming from the gut tube only, portal. This is portal. And superior rectal vein is again portal. So portal plus portal, this cannot help us. You don't want portal anastomosis, you want portosystemic anastomosis. So what about superior and inferior phrenic vein? Phrenic, diaphragm, systemic circulation. This is systemic plus systemic. So you don't want systemic plus systemic. You don't want portal plus portal. What you want is portosystemic anastomosis. So only possible answer in this question can be choice number A, and the diagram now. As you look at the diagram, you can see for yourself that what happens if there is a backflow of blood. See, first you look at the normal, then backflow. So normally what we have mentioned is this is spleen sending the splenic blood received by the hindgut, inferior mesenteric vein, and this inferior mesenteric vein and splenic vein together receiving superior mesenteric vein from the midgut, and together they are forming the portal vein. Portal vein goes into liver after receiving left gastric vein from the stomach, and then it will be some blood filled with gastric metabolites or intestinal the nutrients, and it will be metabolites coming from here, and then there will be hepatic veins which will drain the blood into inferior vena cava. That is normal thing. Now you can see here in this is portal circulation, and portal circulation only, superior rectal vein also is portal circulation. After that, if you say middle or inferior rectal vein, because they drain into iliac vein into inferior vena cava, that becomes systemic circulation. So if we talk about the middle rectal vein or inferior rectal vein, they are basically draining into iliac vein, and iliac vein drain into the inferior vena cava. So that is systemic circulation. That is systemic circulation. So this is inferior vena cava, and inferior vena cava should actually receive portal circulation eventually. But the problem is, you just have to remember the names, like superior rectal vein, portal circulation, middle inferior rectal vein, systemic circulation. Now if there is, let us say, a problem, liver cirrhosis. Now if there is liver cirrhosis, you cannot drain blood into IVC, so blood comes back into portal vein, into the left gastric vein, into the inferior mesenteric vein, from inferior mesenteric vein into superior rectal vein, and then there will be some opening up of anastomosis. The superior rectal vein, portal circulation, and then the middle inferior rectal vein, the systemic circulation, and they are very small connections, dilated, elongated, tortuous now because a lot of blood flow and bleeding. So bleeding per rectum. Similar way, the connection of left gastric vein with the esophageal vein, which is draining into azagous vein into superior vena cava, that is systemic circulation. That is the region where we'll have esophageal varices. A lot of blood coming out because thin connections, dilated, elongated, tortuous, varicose veins, and they can rupture. Massive hematemesis. So the point is, you are talking about two circulations, the portal circulation and systemic circulation. You should know the names of the veins which are involved. So as you come back, you can see for yourself once again, if we are talking about the left gastric vein, it is portal. If it is esophageal vein, it is portal, little bit, but mostly systemic. So portal systemic anastomosis, esophageal varices. Very well, this is our answer because we are talking about portosystemic anastomosis here. This cannot be the answer because middle colic come from superior mesenteric vein, left colic come from inferior mesenteric vein, mesenteric, both of them are portal, cannot help us here. Sigmoidal, inferior mesenteric vein, and superior rectal vein, inferior mesenteric vein, hindgut structures. So it is portal, cannot help us. Superior inferior phrenic is systemic circulation. So systemic plus systemic, if they are opening up, how does it help us? It doesn't help us. So only one thing can help us is choice number A. Now as we move on to the next question, what is the most common complication of major vessel ligation in APR, abdominoperineal resection of the rectum, because there is a CA rectum? They are asking sympathetic as well as parasympathetic. Now, of course, it is a surgery question. These days, they don't ask you pure anatomy or pure surgery questions. They ask you questions from gray area. What is the gray area? Gray area is the area which the anatomy people will think surgeon would have taught, and a surgeon will think anatomy professor would have taught, but actually nobody has taught. This is called as gray area. And somehow my expertise is in this gray area, or at least I try to cover up this gray area. I'll carry my students through this gray area and hand it over to the surgeon, or maybe ENT surgeon, ophtha surgeon, orthopedician surgeon, anesthesia, radiology. That is, I go beyond my territories, but I don't encroach upon other people's territory because they are experts there. I don't talk about much about surgeries, though I may be having quite good knowledge. But here the point is, what is the answer? That is the only point. So what do you think? Before you actually start talking about this, you should have an idea about the nerve supply to urinary bladder. As you talk about the nerve supply to urinary bladder, it will be sympathetic, and because urinary bladder is a viscera, autonomic nervous system. So T12 plus minus 2, sympathetic flow, thoracolumbar flow, sympathetic flow. And T12 plus minus 2 means it is T10, 11, 12, L1, 2. 5 root values to urinary bladder. Now this will be forming superior hypogastric plexus at the aortic bifurcation. When aorta bifurcates, their superior hypogastric plexus, and you will see that superior hypogastric plexus will then continue inferiorly into inferior hypogastric plexus also, so that it could supply the pelvic viscera structures like urinary bladder. What is sympathetic system for? Sympathetic system is for storage, S for S. S for S. Sympathetic is for storage. How do you do storage? Storage, I will relax the detrusor. Relax the detrusor and constrict the sphincter. Constrict the sphincter. So if you relax the detrusor and constrict the sphincter of the urethra, what will happen? Storage. Sympathetic is for storage. What about the evacuation? Parasympathetic is for evacuation. And how do you do that? There is S234 nervi erigantes, and these nervi erigantes, they will be for evacuation. And how do you do evacuation? I will increase the peristalsis of detrusor and relax the sphincter. So if you increase the peristalsis of detrusor and relax the sphincter, what will happen? Urine will go out. Evacuation of urine. So parasympathetic for evacuation, sympathetic for storage, and they balance each other. Normal thing. Now S234 is also the root value of, you can use the other color. S234 is also a root value of pudendal nerve, somatic nerve, which will be, because the examiner has given us sensation. So sensations of the perineum, because perineum is S234. Around the urethra, vagina, anal canal, S4, then S3, S2. Saddle shape, anesthesia, because you are blocking pudendal nerve. Sensation. Sensation is somatic. That is somatic. Mostly, not necessarily. There can be visceral sensations also. This is the overview. Now the thing is, when you were talking about the major vessel ligation, major vessel ligation, you are talking about the rectum. Rectum is hindgut. You are talking about inferior mesenteric artery here. Rectum, hindgut, inferior mesenteric artery. And there is a, dictum that if you want to ligate inferior mesenteric artery, you have to go a little bit distal from the aorta. When aorta gives the inferior mesenteric artery, you have to go a little bit distal. Should not damage the superior hypogastric plexus. Why? What will happen if you damage the superior hypogastric plexus? You have known superior hypogastric plexus is sympathetic, purely sympathetic. So what will happen if you damage it? That is the question. You mean to say answer could be somewhere A or B? Yes. If A or B is your answer, which one? Bladder dysfunction? Of course, there'll be. Because sympathetic is for storage. If you remove the sympathetic supply, parasympathetic will become more powerful. Though it is not so simple, it is a lot of complex things happening, but bladder dysfunction will be there if you remove sympathetic supply. Why retrograde ejaculation? Because internal urethral sphincter is under L1 sympathetic fibers. If you understand that lumbar sympathectomy, removing L1 in Berger disease can result in retrograde ejaculation. So compromising L1 sympathetic fibers, you are compromising internal urethral sphincter. There can be cases of retrograde ejaculation. So is the answer A? Yes, the answer is A. And why not B? Because if you say cutaneous, cutaneous is pudendal nerve, not the sympathetic, parasympathetic. Cutaneous cannot be sympathetic, parasympathetic. It is pudendal nerve maybe. Okay, so you mean to say B is not the answer. Why not CD? Because you are asking what major blood vessel. Major blood vessel, if you compare, inferior mesenteric vessel, inferior mesenteric artery is a major vessel. Though you can come down And in the inferior aspect, you can have, you are ligating the middle rectal artery now. When you're ligating middle rectal artery, you are having inferior epigastric plexus, and you are, of course, compromising even the parasympathetic system. It can be compromised. But major vessel and minor vessel. I'll show you a diagram here, which will give you some idea. This is what we are talking about. We are telling that, let us use green color. This is aortic bifurcation. At the bifurcation, you have superior epigastric plexus, which is purely sympathetic. You don't want to compromise it when you are ligating inferior mesenteric artery. So inferior mesenteric artery, which is a branch of abdominal aorta to hindgut, because you are talking about the rectum removal, you have to ligate the vessels of hindgut. And when you are ligating inferior mesenteric artery, you must be a little bit further from the abdominal aorta, so that you don't damage the superior epigastric plexus, because if you damage it, that is the question, then there will be sympathetic storage compromise, retrograde ejaculation. That was our answer. And what about the middle rectal vessels? If you are talking about the middle rectal vessels, then it will be somewhere here. Now you are talking about S234. S234 pelvic splanchnic nerve. And then you may damage them. What will happen if I damage the pelvic splanchnic nerve, nervi irrigantes? Then there will be problem with evacuation. There will be problem with, parasympathetic system is for erection. And if you say parasympathetic system is for erection, then erection will be compromised. Impotence. Impotence can be a feature of parasympathetic compromise, not sympathetic. Sympathetic system is for ejaculation, and parasympathetic system is for erection. So if you talk about impotence, maybe you have compromised parasympathetic, and both can be damaged. If you read APR, examiner will tell, you have to be careful while you are going through the avascular plane, because obviously you are a surgeon, you have to follow avascular plane to remove the rectum, and in that process, the ligation of arteries like inferior mesenteric or middle rectal should be in such a way that you are not damaging the nerves. I hope this much should suffice our requirements. And though it is, of course, see, this gives you an idea about the next kind of questions which are about to happen, though they are not very new questions, they used to come in our times also, year 2000, when we were giving our PG entrance exam at AIIMS. Such questions used to come. They have reappeared now. They're coming again now. So it's a cycle, one pattern, second pattern, third pattern, again it comes back. The content doesn't change. Pattern of asking questions, that definitely changes. Anyhow, I'll talk more about this when we make a full video. But here, I believe the answer should be choice number A. After going through literature, because I didn't get much of time to read more details. So whatever I have gathered, this appears to be my answer here. Now, this is one question which is asking us about a fracture, and fracture at which point leads to loss of dorsiflexion, means foot drop. We know foot drop can be injury of common peroneal nerve, but it can also be injury of deep peroneal nerve, which is also called as anterior tibial nerve. Mostly common peroneal, but it can also be deep peroneal, clinically. Now, this is patella in front of lower end femur. This is tibia, the tibial condyles, shaft of tibia. This is neck of fibula, head of fibula. So they have given some points, and as you can notice yourself, fracture of the lateral condyle of the femur doesn't make sense, doesn't happen so often in clinics. Fracture of the head of the fibula, but fracture neck of fibula, of course, and common peroneal nerve and foot drop. Can you have foot drop even here? Yes. Though it is again a rare thing, clinically doesn't happen, but you may damage the peroneal nerve and leading to foot drop. So you mean to say your answer is C, better than D? Yes, my answer is C, and it is a better answer than D. As you will go through the details, you will understand yourself. So, where is the lesion? See, sciatic nerve is giving us common peroneal nerve behind the knee joint. It is called common because it is further going to divide into two, social deep branch. Related to the neck of fibula, if it is damaged, there will be a problem called foot drop, loss of dorsiflexion, L5 problem, L5 root value. Now it is giving superficial peroneal nerve, the nerve of eversion, turning sole outside. And then it is giving deep peroneal nerve. Deep peroneal nerve is also called anterotibial nerve because it is going anterior to tibia. And it is the anterior tibial nerve which is for dorsiflexion or extension at the ankle. So my point is, if you damage common peroneal nerve, you obviously damage the deep peroneal nerve or anterotibial nerve. That is why there was loss of dorsiflexion. But it can also be injury or fracture to the shaft of tibia. If there's a fractured shaft of tibia, again there will be foot drop. But this is a better answer because clinically more frequently happening. This doesn't happen, it's very rare. It's very rare to have injury of deep peroneal nerve or anterotibial nerve resulting in foot drop, though there are cases. There are. So this answer is better than this answer. And of course, if you have injury of common peroneal nerve, superficial peroneal nerve is gone, so there will be a problem of foot eversion as well. And deep peroneal nerve is gone, so loss of foot dorsiflexion, which is foot drop, and sensory loss. Sensory loss, lateral, leg, and most of the dorsum of the foot. Most of the dorsum of the foot, including the dorsum of the first web space, L5 on foot. Dorsum of first web space, L5, deep peroneal nerve. Otherwise, most of the dorsum of the foot is supplied by superficial peroneal. But both of them were compromised in this case. What will happen if only deep peroneal nerve is damaged? Then you will not have sensory loss on the dorsum of foot entirely, but just restricted to dorsum of first web space. Plus, there will be only foot drop, no loss of eversion. Loss of eversion is because of injury to the common peroneal nerve, because superficial peroneal nerve is gone. So difference between these two cases will be, in this case, eversion is okay. In this case, most of the dorsum of the foot sensation is okay. So this is what I wanted to tell you finally, that please understand, please kindly, it is a recall session. You have to contribute. In the chat you can write, because the YouTube session will be there, you can write in the chat, I'll read. I always go through the chat, but most of the time I find that I don't need to give any response, because you are already wise people, you know almost everything. But we need your help because I didn't give the exam. You people have given the exam. You have to give me STEM and the option, the diagrams. Kindly contribute. Final video discussion will be uploaded once we have highest approximation. See, the problem is, what I have seen is that we just try to accumulate some information and just make one answer and forget about it. I do not believe in that. I do my work sincerely, honestly. So I'm a bit delayed also. My videos are delayed because I just don't want to do some formality. You cannot stay in the field if you just believe in formality. You have to do your job. You are paid for your job. You have responsibility. You people should become good doctors. That is my responsibility. That is our fraternity's responsibility. That is the responsibility of your seniors. I cannot be casual. So it is well understood a change in the wordings of the STEM or option can change the approach. Please help us to reach the highest approximation, and then I'll give you the perfect answer when the video is uploaded. All the best for your results, and send us the happy news at the earliest possible. God bless.